this article, this article has been published in July of 2021, this year. This is a brand new journal, but it's international, has authors from many countries in Europe, a few authors and from United States. So it seems to be a decent article and scientific and evidence-based. So basically, but I'm going to start actually with another article that is published in the American Thoracic Society. This is one of the major three societies dealing with a pulmonary and critical care medicine. It has a very high rating journal, and this is published in August of last year. And it's talking about why COVID-19 silent hypoxemia is baffling physician. And so this was basically the abstract. It's talking about patients with coronavirus, COVID-19, were described as being coming with very low oxygen levels, almost incompatible with life, but yet they're not short of breath. They're not complaining of dyspnea. They're not looking like they're struggling. They're just walking around with considerable amount of comfort level, but when you check on their saturation, is very, very low. So basically, this is combination attracted people and also the media actually to talk about this one even before the medical literature. And so they're talking about like, okay, and they call it more a silent hypoxemia or happy hypoxemia. Basically, patient does not look any symptomatic, but yet their oxygen is very, very low. And then the question is whether this is idiosyncratic actions of the COVID-19 virus. And in this article that I mentioned, they reported first 3 cases where they had at their institution, and they looked at these cases in terms of their age. The first case, the patient was a 64-year-old male. He presented on a 6 liters of nasal cannula. Saturation was 68%. PO2 on the gas was 37. PCO2 is 41. And I'd like to pay attention to this, like the CO2 as being 41 or around 39, because that's going to be important in a discussion. But yet when this patient was asked whether they're short of breath, and they said they're no, they looked to observe that they're using any accessory muscles, or they're showing any increased work of breathing, abdominal muscles. Again, that was no. And the first patient has a comorbidity, diabetes, coronary artery disease, hypertension, renal transplant, and carotid endarterectomy. So a pretty sick patient on the first case. The second patient was 75-year-old, also male. He's on 50 liters nasal cannula. Saturation is 62, PO2 is 37, PCO2 34. And again, this is important because normally PCO2 is 40. So this is below normal and it's below 39, which we know we're going to see what's the importance of this number. Again, they're not short of breath, they're not using accessory muscles, and they have no comorbidity. The third patient was also male. He was 58. He was on high flow nasal cannula, also has low saturation. PO2 was low, PCO2 was low, also not symptomatic, and no comorbidity. So this article is actually came after another article which was published in the New York Times in April of 2020. And the title for that article was "The Infection That's Silently Killing Coronavirus Patients." And then in this article, they talked about the silent hypoxemia, or they call it happy hypoxemia. So this was written by Richard Levitan, who is an ER physician. So basically, in this article, they're talking about the mystery of a large number of COVID patients arriving at the ED with a very low oxygen saturation to a point that they should be unconscious, but yet they're walking and talking. if we look at it scientifically, we find this is a defying basic science, because the low oxygen saturation should not be compatible with life. The way we know it, the way we studied in medical schools, that the PO2 has to be at certain levels, 60 and above, otherwise you're gonna have tissue damage and stuff like that. But here, the picture is different. Dr. Levitan, who's an ER physician with 30 years experience, he described the majority of these patients when they come in with COVID-19 pneumonia, they're coming with a very low saturation, incompatible with life, but yet they're using their cell phones with minimal distress. So going back to the basics, and physiology is how respiration, how physiology as we know it from traditional books. So when we have, generally speaking, a viral infection, when it affects the lungs, you're gonna cause inflammation, and then you're gonna have a stimulation of the chemoreceptors, which as a result will cause dyspnea, increased respiratory rate, as a result of the hypoxia. So that's normally what happens when you have viral infection and you get stimulation, and patient will get a short breath. But then they said short of breath, or what is defined short of breath, is basically an unpleasant breathing. So just like how we define pain is an unpleasant sensation that only the patient can characterize or quantify, they're saying that short breath is also a subjective, that's only the patient can tell you if they're short of breath or not. So basically, if they're breathing with respiratory rate in 20s to 30s, but they don't feel short of breath, then they're not considered as dyspneic. That's different than the signs that we looked at it, whether it's a tachypnea, so like breathing above 20 or 30, if you wish, tachycardia, or looking at the facial expressions. These are signs of dyspnea, but the main question is that does the patient feel short of breath or not? And that's what we're referring to when we're saying silent hypoxia, is that actually the patient is not complaining of short breath or difficulty breathing. So again, look at the respiratory centers. So we have two types of receptors. We have receptors in the carotid body. They are sensitive to the PCO2, how much CO2 we have in the blood, and another receptors that are sensitive to the PO2, is how much oxygen we have in the blood. And but it's very clearly documented. These receptors are much more sensitive to the changes in the PCO2 than the changes in the PO2. So for example, an increase 10 millimeters of mercury of PaCO2. So instead of normal 40, if it goes to 50, that can increase the minute ventilation twofolds or threefolds. However, on the other side, hypoxemia. So hypoxemia is defined as being low oxygen levels in the blood. So hypoxemia is different than hypoxia. Hypoxia is low oxygen in the tissues. Hypoxemia is low oxygen in the blood. When that happens, it will stimulate the carotid body, and the carotid body will send signals to the medulla, and the medulla will respond by sending different signals to the phrenic nerve and the diaphragm, and that's when the increased respiration and increased minute ventilation occurs. At the same time, the ventilation response to hypoxia is hyperbolic, meaning it's not linear. It doesn't happen very clearly. So with this graph, so hypoxia has to go really low before the minute ventilation goes up. So I'm trying to see the graph here. But basically, when the PO2 goes down from 120 to 60, there's no much changes in the minute ventilation, really. So it can drop to, almost has to drop to like the 50s or the 40s until you start to see like a sudden and exponential increase in the minute ventilation. But anything before that, it will not happen. And then the other thing, important thing is that ventilation will only increase if the PaCO2 exceeds 39 millimeters mercury. This is based on studies. So in other words, it's probably both these two things has to happen at the same time in order for the minute ventilation to go up. So if the PaCO2, and that's usually most of the time when we have somebody come in the hypoxic respiratory failure, they usually have increase in the PaCO2 in the upper 40s. And as a combination of these two, you will have increase in respiratory rate. But then secondary, when hyperventilation occurs as a response to the hypoxia, then the CO2 will go down. But at least anytime the CO2 goes up, that's already triggered the dyspnea. But if the PaCO2 is almost maintained below 39, even with a low PaO2, that minute ventilation might not change because it's more sensitive to the PaCO2 than to the PaO2. Okay, so again, in this study, they took an informal poll. They asked 58 physicians, different hospitalists, emergency physician, and intensivist about, the question was, have they seen patient with silent hypoxia or happy hypoxia? They only got 37 responded. 15 of them did not really provide any useful data. But out of the people who responded with useful data, 19 had an ABG. Of these, 16 had a PaO2 less than 60 without dyspnea or short breath. 7 out of 16 had a PaCO2 more than 39, anywhere between 41 to 49, with PaO2 less than 60. And they were considered as being silent hypoxia because their PaO2 were less than 60, which is the cutoff of when the saturation will be less than 90. But in 9 out of the 16, where they had a PaCO2 less than 39, anywhere between 29 to 37, they did not have a silent hypoxia. So in COVID patients, there's a good number of COVID patients. Specifically, I mean, we have to remember that COVID patient mostly was hitting the elderly or people with comorbidity, either diabetes. So those people are prone to have a poor response to respiratory control to hypoxia. They might have a neuropathy that could affect their response to increased minute ventilation. Generally speaking, in people over 65 years of age, their ventilation response to hypoxia decreases with age. Older people are more prone to silent hypoxia because their receptors are not as sensitive. And like everything else with aging, those receptors does not respond appropriately. The ventilation is also response to hypoxia is also decreased by 50% in elderly. And lastly, the chemical drive to breathing, there's a lot of variation between individuals and people from person to person. So really how one person reacts to hypoxia can be different from another's. So there's a lot of variation that cannot be all universal. So hypoxemia as a threat to lives. So physicians are always fearful of hypoxemia. We always panic when we see saturations 80–85%. We think this is a life-threatening. It's a panic button. We have to always activate and react and give oxygen and get ready for mechanical ventilations, because we are all learned and trained that the saturation should not go below 90. Otherwise, tissues will start dying and brain cells are going to start dying, and that's a big liability. So we were not allowed as a trainees or practicing that saturation should never go below 90s. However, the author is mentioning that she was part of a volunteer in a study where they did study the effect on the hypoxemia on the breathing pattern, and they were allowed to have a saturation between 80 and they had it like for over an hour with a low sat in the 80s, but they were non-symptomatic. None of them were symptomatic. And there was no difference between saturations in the 80s and the 90s. There was also some investigation controls where some of those individuals dropped their saturation to 75 or even briefly to 45, but there was really no serious harm when this was done for a very short period of time. So again, they're talking about, are we sure? I mean, is it really dangerous for the saturation to go below 90s? Nobody really sure, but from what we know so far, it's not, it's not as lethal as we're always afraid of. And the last one is a tourist. When they go on top of Mount Evans, which is near Denver, they experience a very low saturation for a prolonged period of time, but they're not very uncomfortable, or very few will be dyspneic when they're exposed to low PO2. So again, going back to the machine and the pulse oximetry and how it's designed and how it works, the pulse oximetry basically eliminates light on the skin, and it will measure two wavelengths between the oxyglobin and the reduced hemoglobins, and as a difference, it will measure the oxygen saturation. There's always a margin of error with these saturations, plus minus 4%. So it's never 100% accurate. There's always a possibility for discrepancy. And also it's less accurate, less than 80%, because I mean, obviously when these machines were made and were calibrated, they were calibrated on humans, and most accurate between 80s and 90s. You cannot allow the saturation to go to below 80s, and therefore the calibration was not meant to be for any saturation below 80s. It's more like extrapolation of the data to, or like a guessing of what would be certain wavelengths, what will be the saturation. So we all know that generally speaking, saturation below 80 is not accurate. And then we have to rely on getting a blood gas to make sure what the PO2 and the saturation on the gas before we decide to plan, especially if we're planning major interventions to correct that. So basically, saturation can be underestimated by at least 7%. So that's why a blood gas is always good to confirm the number. And then here again is like the difference between the saturation on a blood gas versus a saturation on an O2 sat monitor. And if we look at the line, the solid line, show you pretty much like rough correlation. There's also two lines. So it depends on the variation of the people, and this each dot or each circle, this is representing a different patient. So there's a lot of variation between people and almost all over the place. So at some saturations, 50 can correspond to 20 on the SAT monitor, versus some other patients, 60 corresponds to 60. So it's not really fully accurate, but it's a best estimate rather than checking a continuous blood gas saturation. But that also has to be kept in mind when we're looking at the saturation of the monitor. So there's also the possibility in the shift of the oxyhemoglobin dissociation curve. As we know, this curve is not linear, and it's, the more the PO2 increases, the more the affinity of the hemoglobin increases, and then once it's above 60, which is the acceptable levels, we rely on this graph to judge that PO2 of 60 is the ideal, because that's when it put us saturations above 90 and between 90 and 100%. But that curve can also shift. So example, you see that there's the solid line is the normal line, but the dotted line is for patient with increased fever. So when you have fever, then you have a shift to the right. What that means is the hemoglobin will more easily give up the oxygen to be diffused to the tissues. So it will reflect a lower oxygen saturation, but that's not necessarily more harmful to the patient. Here's another graph where it show you the other factors that could shift that hemoglobin, oxyhemoglobin association curve, factors that can shift it to the right and shift to the left. So to the right, we have the increased PCO2, decrease in the pH, increase in the temperature, hemoglobin SS or DPG. That all increases it to the right. But there are factors that can also increase it to the left, meaning when it's shifted to the left, it will hold on to the oxygen much more. So even if the saturation is higher, but that means oxygen is less available to tissues because the tissue diffusion will be reduced. Okay. Then COVID-19 and the silent hypoxemia. So it's possible that the COVID-19 had some special effects on the respiratory system. We know that the virus binds to the ACE2 receptor, which is the target of the SARS-CoV-2 virus. These receptors are present at the carotid body. So if the virus attached to the ACE2 and it's present in the chemoreceptor, it's possible that is muting the effect of on the carotid body. So that does not cause increased respiration. ACE receptor is also present in the nasal mucosa. So that's why some patients complain of loss of smell. And then the olfactory bulb can provide the passage of the coronavirus to enter the brain. So whether ACE2 receptors play a role in depressing this dyspnea, that's also a possibility. So now I go to the second article, which is how should we manage the hypoxemia in SARS-CoV-2 based on what we've learned, based on what we've seen in the last year. What's the best option or course to manage those patients when we knowing all these things, and how we can help them. So as an introduction, again, talking about the scientific evidence, there's really not solid evidence. We've been over like a year and a half dealing with this, and I can tell you, like, from taking care of those patients for the last year and a half, every time we go to the hospital, so every month, I used to cover the ICU, I got cover like a week or two at a time, and then I take a break and come back. Every time we take a break and come back, something has changed or something we're doing differently based on the different information that comes out. And that goes from the early stages where the hydroxychloroquine came in to the play, then to the steroids, then to the tocilizumab, and then remdesivir, all these kind of things. It's evolved over the last 2 years, and finally now we have some of way of say this is the best we do it, but it's really not. We're not sure that's actually the best management so far, but this is the best evidence that we have based on the information that's been collecting. And then the same thing with the management, the hypoxemia. I remember the first publication that came out, because we didn't know how to deal with this and we needed some guidance. And the first thing came in from Cleveland Clinic was, do not use high flow nasal cannula oxygen. Do not use non-invasive ventilation. Anytime you have this, they have to be in negative pressure room, and then they have to be intubated, so to limit the transmission of the viruses. But then that changed. within 2 months, we changed and we said, no, we can use high flow nasal cannula, we can use non-invasive, they just need to be in a negative pressure room for transmission. And then we have to have a PPE for everybody that's interacting with this patient. So with COVID-19 also, there is an endotheliitis and vascular thrombotic events. And that makes it different than any other type of ARDS or respiratory failure, where the primary insult is actually on the alveoli and inflammation in the tissues. So it makes it a little bit different and unique in how, in terms of the management as well as the manifestation of these. And again, a definition of hypoxia here is reduced oxygen in tissues. And that's when you notice that there is a lactic acidosis or an anaerobic metabolism. And that happens a lot with the bacterial infection. Whenever bacterial infection comes to the unit or the ICU, we activate what's called code sepsis. And part of that is to check the lactic acid. And the lactic acid with sepsis is almost always elevated. And that usually indicates shock. And by definition, that's considered shock because there is a poor perfusion to tissue perfusion. And that triggers all kind of different protocols to reverse that lactic acidosis. But when we look at COVID, very rarely we see, I have not seen lactic acidosis with COVID. So that means even though there is hypoxemia, we don't have an evidence that there is actually hypoxia in COVID as a result of poor oxygenation. And the hypoxemia on the other side is defined as decreased arterial pressure of oxygen less than 80 or less than 60. So to speak, means like there's low oxygen in the blood, but that doesn't necessarily mean low oxygen in the tissue and organs. So what are the mechanisms of hypoxemia in general? What drops it? So basically, either you have decreased ventilation, it means there is no air coming into the lungs. So if somebody stopped breathing, or somebody has an obstruction upon airway of aspiration, immediately their oxygen is going to go down. If we have a shunt, meaning like the blood is passing through the lungs, but it's not participating in gas exchange, or either shunt intrapulmonary or extrapulmonary. So the blood can actually passes through the lung, but if the alveoli are collapsed, like if they have a lung collapse, or if we have an atelectasis, that's a definition of shunt, means the blood is passing through the lung, but is not participating in gas exchange, and that's going to cause hypoxemia. Third one is a diffusion. If there is pulmonary fibrosis or interstitial process, such as inflammation or sarcoidosis or whatever, any disease that will prevent the diffusion between then that's also going to cause hypoxemia. And next one is a perfusion. Perfusion, if we have a blood clot that's blocking the blood to go into the lung to beginning, so that's by itself is going to cause dead space and is going to cause hypoxemia. And the last one is a mismatch, when we have the blood is going in one area of the lungs that is perfused but not ventilated, and some other areas that are ventilated and not perfused. And that's actually can be manifested here. This is one of the cases that is what's considered as being a normal chest X-ray, where the patient presented with hypoxemia, and they did a VQ scan. And it's a nuclear scan where you see perfusion to the lungs and try to match it with the ventilation. And this patient could not get a CT angiogram where we'd be looking for pulmonary embolism. So the second one best was VQ scan. When they did a VQ scan, you can see where the arrow is. There are several defects in the perfusion and ventilation area, which indicates there is some, not necessarily an embolus per se, but they noticed some mismatch. But when they got the CT without the contrast, they noticed that there's actually this area of infiltrating posterior, and they diagnosed the COVID this way. So COVID does cause mismatch in the perfusion and ventilation area, and that can cause the hypoxemia in some areas. So, and this is the west zones of the lungs as defined by like 3 different areas. So basically, if you look at the gravity, so the apical part of the lungs on top, where you have the alveoli is wide open and they're ventilated, but sometimes the air pressure is much higher than the alveolar pressure. The capillary pressure, the alveoli is much higher than the capillary pressure, so you can have a collapsed capillary, and that's by itself is defined as a dead space when you have a ventilated alveoli that are not perfused because of the pressure in the top of the lungs is not generating enough pressure in the vessels to open and that's usually a small area on the top of the lungs. The majority of the lungs in the middle, where you have a gas exchange zone, where you have an open alveoli and then also an open capillaries, and that's when the gas exchange happen in that area. As you move down to the bottom, and as an effect of the gravity, so you have an increased capillary pressure that can press on the alveoli and causes atelectasis, and that's by definition is a shunt, where the blood is actually passes through this area and no gas exchange happen. And again, the top and the bottom usually are small areas. The majority of the lung participate in the gas exchange, but this is just for demonstration purposes. So with the silent hypoxemia, so hypoxia usually causes short breath and increased work of breathing. So what they're saying in this article is that we can use a high flow nasal cannula, proning or non-invasive to correct the hypoxia. And COVID-19, there is the possibility of hyperperfusion or hypoperfusion area, as we demonstrated, that actually in COVID, there is discrepancy. It's not all universal. And then usually when you look at the X-ray or CAT scan, we call it multilobular infiltrate, means multiple lobes are involved and not in a universal way like pneumonia or ARDS. It's more like kind of patchy areas, and sometimes involves both anterior and posterior areas of the lungs. So it's much more broad and involving both lungs and both most of the lobes. So on ARDS, on the other hand, it's only alveolar involvement. With COVID, you have an alveolar involvement, inflammation, but also there's also vascular involvements with microemboli, and that makes it even much more complex in terms of hypoxemia. So what's a possible pathophysiological mechanisms? We talked about the shunt effect. So that's a possibility because you have a small areas that are collapsed and involved, like inflamed, that will cause a shunt, meaning the blood is going to pass through the lungs without gas exchange because of damage of the alveoli. There is also patchy alveolar involvements. Microemboli perfusion can cause the other ways, like basically dead space, when you have an areas that are ventilated but are not perfused because of the emboli. But generally speaking, hypercapnia is much less common. Few cases I've seen in the past where they have a increased dead space and increased PCO2, but that's a very late stage. Most of the time, they have low CO2 because CO2 is very easily to diffuse through the lungs. So even a minimal tissue in the lungs is enough to exchange CO2, while the oxygen requires much more effort to move across the alveolar capillary bed. Again, in comparing this to ARDS traditionally, with COVID, there is not always an increase in change in the pulmonary compliance. So we don't see what's we always use in the ARDS, where like stiff lungs or increased resistance. They're also not common to see increased peak airway pressure and increased plateau pressure. It's usually very easy to put people on PEEP, not worry about plateau. But so that's the argument that it's the COVID is different. We can consider it as ARDS, and therefore the management should not be the same as managing ARDS. So non-hypoxic hypoxemia, hypoxemia, if we define it as PaO2 between 40 and 60, hypoxia is low in oxygen in tissues and cell. Hypoxemia is a very weak stimulant for dyspnea, as we've seen before. The body responds to high CO2 because it's 20 times more soluble. So it's more sensitive to increased CO2 than drop in the PO2. And we see this also in COPD patients, where we call them, they live in 50-50 club. PaO2 is 50 and PCO2 is 50. But because their receptors are blunted to PCO2 and their CO2 is being chronically elevated above in the 50s, so they only respond to the low O2, and we always taught not to give them too much oxygen, because if you give them too much oxygen, then they will go apneic, because now you blunted their response to the hypoxic drive. So they live in a very narrow margin, but shows you how the receptors are more sensitive to CO2 than the decrease in PO2. Again, increased oxygen toxicity, there's a possibility of oxidative process that could lead to endotheliitis and causes inflammation and lung fibrosis. And that's an argument against giving too much FiO2, so to speak. So giving 100% oxygen, so we can get somebody to 93%, as recommended by the ARDS net. If we have to give somebody 100% to get their saturation 93%, so that we are happy and satisfied, we might do more worse than good for this patient, because he could be setting 88 to 90% on 50%, and he can avoid this oxidative damage to the lungs, just not to chase the 93%. So the last question is, does SARS-CoV-2 affect O2 transport by the hemoglobin? Does it affect the hemoglobin function in general? We don't know that. So based on this article, the recommendation was accepting saturations less than 93%, and I'll show you that based on the ARDS nets and most of the people in the pulmonary, they consider 93% as a target for ARDS. That is actually can be considered. We should accept much lower than this number, maybe somewhere in the 80s, if the patient is comfortable and not showing any end organ damage and any change in mental status. And this article is advocating using the high flow nasal cannula or CPAP, but the CPAP is a weak evidence according to them. And mycolytic can help loosen the secretions and can help the gas exchange if you're able to help them get rid of the secretions. There's a lot of secretions with COVID. And in this article, the intubation has to be only the last resort and life savings. And based on the saturation, not based on the saturation number alone, we have to look at the patient in general. What's that saturation look like? What's the work of breathing? How much they're struggling? They're using accessory muscles if they're tired. So I can tell you how many times I got called at 1 o'clock or 2 o'clock in the morning because patients breathing in the 40s and everybody's panicking because their saturation is 88%. But we have to do a lot of education to tell people is like, okay, we have sometimes to accept these numbers if the patient is comfortable, because the alternative might not be better for this patient. So if the patient appears to be tired, patient has some change in mental status, or they have multi-organ failure, for example, cardiac dysfunction showing ischemia or hypotension, then this is definitely a clear indication that the patient is reaching the end point and they have to be intubated and mechanically ventilated. So then I'm going to talk about I went to the Society of Critical Care Medicine, try to see what they have for guidelines published in terms of the management of adult patients with coronavirus. And this is on their website. This is the algorithm for indication for mechanical intubation. And say if there is an indication for mechanical intubation, patient should do endotracheal intubation, use N95 and minimize. Tolerating supplemental oxygen, then we should give them supplemental oxygen. Consider high flow nasal cannula, but if there is an indication, then they have to go for intubation. And then if you look on the right, I think that's the confusing part that I feel like, is because when we look at this is saturation is 92 to 96%. So, and I think that's what we're trying to revisit here, is this really the number that we should go by, or we should accept that if the patient is comfortable and not short of breath and they're tolerating and maintaining, that we should accept around 90 or 88% or lower number. Because 92, 96, we're going to be intubating a lot of people, and the outcome is not always good, as I'm just going to show some couple articles. This is the rest of the recommendation from SCCM. So basically, they're following exactly the ARDS NET protocols. So say COVID-19 with mild ARDS, COVID with moderate to severe, we're going to use PEEP, traditional recruitment maneuver, proning, and antibiotics. And again, target saturation 92 to 96%. So basically, this is the same as the ARDS recommendation, and that's where the argument is. It's like, is it really the same as ARD, or this is different, unique lung mechanics disease? Then the next question is, when is the timing for intubation in patients with COVID? And this is another article that is published in CHEST, and this is very respectful, also with a high impact journal. And they're trying to say, when is the best timing for a patient with COVID-19? And then referring to the earlier in the pandemic, there was a push for early intubation for fear of transmission. And but then with time, we started to accept the high flow nasal cannula non-invasive devices as being acceptable alternative. And we all delayed the intubation until late. But then we were criticized because we were like meeting regularly with the expert, trying to figure out what's the best strategy. We followed this for a while, but then one of the meetings said, no, we have to do early intubation, because if you wait until patient is tired on high flow nasal cannula, or they're tired on the CPAP or BiPAP, and then you intubate them, then they missed the opportunity. And then we started doing early intubation, and we got good results for a while because we had a low trigger for intubation. And so we had a mixed picture. Some people did really well with intubation, some people didn't do well. So we were not really very clear about what's the best to do. And up until recently, I was just talking to one of my colleagues in my network, and a couple months ago, he was like, yeah, we should do early intubation. Don't wait too long on these guys. You have to do early intubation. But then now, just recently, I spoke to him, and he's like, "Don't push for intubation too early." So we're still like, trying to figure out what's the best way, because we have mixed results with people when they get intubated, and then we have mixed result with people they're on none. There's no clear evidence, but I think more and more with accepting this, if this was become more acceptable as to accept lower oxygenation with a silent hypoxemia, that we could probably intubate less people, and maybe they'll have a better outcome. So again, an intubation in this article saying you have to show, you have to see hypoxemia and oxygen saturation, but also rely on the tachypnea, increased work of breathing, muscles, and nasal flaring. Also participate the patient with the input is useful. Are they breathing comfortably, talking? If they're talking, they're probably unlikely to need intubation. So they were using in this article is Cabrini respiratory strain scale, which basically combine all these things to see what's the best approach for patient to intubate or not to intubate. And this is they had a retrospective study collected about comparing early intubation, and early is defined as been done within 24 hours after admission to the ICU. And they found no association with mortality, duration of ventilation, or ICU stay when they did early intubation versus late. Late ventilation, the rate of ventilation acquired pneumonia, bacteremia, and ICU length of stay was worse actually with intubated patient, obviously. Another study showed that longer ICU stay with late intubation. So when you do late intubation, you might end up with having lower ICU studies. So you can see the results are mixed based on different studies. So in summary, there's the current evidence does not show meaningful evidence that early or late intubation, the ultimate decision should be based on the clinical decision of the experienced intensivist, looking at the oxygenation, respiratory distress, and work of breathing. So, and the last one I'd like to throw, this is like what are we giving up when we doing an intubation, and what are we gaining when we doing the intubation? I just had a recent actually case that is like made me really change my mind about the intubation, where we had a young guy who was struggling with COVID, and he was sat, it goes on 100% oxygen with BiPAP, and his oxygenation was like 85, 86 at best. He was breathing in the 40s. He looked kind of like very tired, very exhausted, with difficulty breathing, but yet he was fighting. I mean, every time we mentioned to him that, maybe we should do maybe we should do the intubation, and he's like, I only do it if I'm not gonna make it or get tired. So eventually he got to a point where he was like really, really tired. He couldn't go anymore. And I was like, okay, let's go ahead and intubate you, thinking that, maybe by intubation that we can increase the FiO2, because when the advantages of intubation is basically you can have a better seal, you can put an endotracheal tube, you can adjust the pressure and the PEEP and make sure the alveoli are open. So at least most of the lungs are ventilated, nicely ventilated, and you allow to minimize the mismatch and increase the PO2 this way. You can also give 100% oxygen. This way, there's no leak. But then we did that and we intubated him. And to my surprise, to everybody else's surprise, there was zero change in the PO2. I mean, it's almost no, we did not gain anything. His saturation was in the mid to upper 80s at best. We sent him to the scanner to see if maybe he has a PE. He did not show that he has any significant size of PE, so that was not there either. And he continued to deteriorate. The intubation didn't make any difference. But then, I mean, look at this this article. It's like the connection between the autonomic nervous system and the immune system interaction. When we're doing the intubation, patient has to be sedated. They have to be anesthetized in order to tolerate the endotracheal tube. And by doing that, basically, we're knocking down their autonomic nervous system. You're giving them anesthesia, so their ability to fight the disease now is completely blunted, basically. And based on this article I was just reading, is that there is a connection between the immune system and autonomic nervous system, and so that the autonomic system, including the sympathetic and parasympathetic innervation, can have contribute to the cytokine-induced changes in efferent parasympathetic and sympathetic nerve outflow, leading to modulation of peripheral immune responses. So, it's important to remember that by doing intubation and sedation, we are losing that piece. So, if the patient, because unlike ARDS or other diseases where the disease because of bacterial infection or chemical pneumonitis, that the body doesn't need their immune system to fight the disease. With COVID disease, we don't have any specific antivirals, and the only defense against the disease is the ability of the immune system of the body to fight that viruses. So when you intubate and you sedate, you take that away from the system. So that has to be put in consideration before intubating patients, because we're losing that part, and a patient will just be subject to how good the oxygenation and how is fight against COVID without the autonomic nervous system power. And that's all what I have for tonight. I don't know if you have any questions.
Well, great presentation, Dr. Issam. I mean, this is the one of the best among all the series that we present. I think it shows that we still have a problem of understanding and looking for the best protocols to manage ICU COVID patients, which is very critical because we still have 300,000 people dying this year and 300,000 died last year. So there's not much change happen. If we're able to adjust the protocols in the ICU, we may be able to save 50% of those people who are dying. But your presentation was excellent. I like everything about it. You're fair on both sides. And that's how I think the way that we learn, we don't want to be biased. We want to learn from both sides and both perspectives and coming up with the common ground. But let me just go a little bit and follow up what you're going through COVID-19 versus, which is silent hypoxia versus other respiratory failure. I call them reactive hypoxia. And when you inhale COVID, and those COVID viruses, they have spike protein. Those spike protein are vasoconstrictors because we know they activate the angiotensin type 1, angiotensin 2 type 1 receptors. So they are vasoconstrictors. Think about when you inhale the spike proteins or you inhale those viruses, you're inhaling a vasoconstrictors. And when you inhale the vasoconstrictors, what will happen is that normally when we inhale oxygen, oxygen will go through the alveoli or the ventilated area of the lung, right, which has more oxygen, and the oxygen will go to the blood, to the surrounding capillaries, and they will be pushing the nitric oxide out, because oxygen will be kind of changing the hemoglobin and make the hemoglobin be released from the blood and causing the vasodilation. So this would help the ventilation perfusion matching, because where you have more oxygen, you will have more blood flow. Why? Because the oxygens will help to squeeze those hemoglobins in the blood, the nitric oxide out, which leads to the vasodilation there. Okay. So that is the mechanism of the ventilation perfusion. When you have this spike protein that's coming up with the virus, those spike is vasoconstrictor. So it will counteract what oxygen is doing, which is releasing the nitric oxide from hemoglobin. So it's going to cause vasoconstriction. So the area where you have the virus is going to have vasoconstriction, and this will lead to perfusion ventilation mismatching, because it is counteracting what the oxygen is doing, which is increasing the nitric oxide release. Well, that's right. But then if you have the vasoconstrictor, this will counteract what nitric oxide is doing, right? And causing vasoconstriction, and that leads to the mismatch. So this is one mechanism. The other mechanism of mismatching is that those spike proteins, they activate the platelets directly and causing coagulation, and in this case to blockage of those capillaries. And this is another mechanism of mismatching. Then you will not have much blood flow going to the ventilated area. So that's the second mechanism. The third mechanism, those viruses possibly, those spike protein, they will be infecting the bioreceptors, as you mentioned, of the carotid blood, the carotid bodies, and that will make the people or make the patient insensitive to the oxygen level, and that lives in what we call the silent hypoxia. And the third mechanism is that we know this COVID virus is causing polarization of the immune system to Th17, and you have overproduction of interleukin 6. And interleukin 6 co-stimulation in the peripheral tissue, it causes stimulation of inducible nitric oxide synthase, and you have too much of nitric oxide, but nitric oxide that react with the free radicals and become peroxynitrates in the peripheral. And what does that? In fact, this nitric oxide that's going to be produced because of the COVID infection and because of the polarization of the immune system to Th17 and overproduction of interleukin 6 and too much of nitric oxide in the peripheral tissue can cause blockage to the mitochondria. And this is what we call the hibernations. And not just that, those nitric oxide in the peripheral tissue will definitely, what would happen is exact the opposite what's happened in the lung. Those nitric oxide will squeeze out all the oxygen from the hemoglobins and move the oxygen away from the hemoglobins into the tissue. So squeeze them. And that's why you see the curve is being shifted. And you will see the difference between the PCO, the partial oxygen pressure and the oxygen saturation, because too much of nitric oxide in peripheral tissue is squeezing out all the oxygen from the blood. And that's why you'll see the when you do the oximetry, you will see it's kind of lower than they're supposed to be. But still, that's a good thing, because when you block those mitochondria, you are decreasing the use of oxygen. So the patient does not struggle to get the oxygen, because it's like hibernating those patients. Now, what's the problem here? And this patient that you put him on intubation, we have something that's called reperfusion injury, and that's something we need to learn about it. What is reperfusion injury? If somebody has ischemia, heart ischemia or stroke, right, and you open up their thrombus by the procedure that we're doing, right, thrombolectomy, or you add streptokinase and you break down those thrombus and you have sudden reperfusion, this reperfusion can cause damage to the heart even more and cause damage to the brain if you have stroke. And that's one of the problems that we have. And one way of managing reperfusion injury is giving the patient IV glutathione, methylene blue, and something that will help to buffer the free radicals that's being generated when you reperfuse. And the mechanism is such: when you have cardiac MI and you block the oxygen from going to the heart tissue, what will happen here is that there is no much oxygen, so the mitochondria will be blocked, right? So it will decrease their oxygen utilization. It's the kind of mechanism that the tissue does, or the heart does. And what would happen when you open up and you allow the oxygen to go in? It's like opening up, flow of oxygen. Then the mitochondria is being blocked, so there's no way to utilize the oxygen and generate water, because the mitochondria cannot move the electron chain is not moving to end up with water. So you end up with too much of free radicals, and that's called the reperfusion injury. Too much of free radicals, which causing the damage more into the heart. So that's why it's in the favor that if you are having patient with MI, before you open up their blood vessels or their thrombus with streptokinase or thrombolytics, it's better to put the patient on IV reduced glutathione or methylene blue, vitamin C, all of this, which helps scavenging the free radicals and preventing the reperfusion injury. In this patient that you said we did not give them the intubation, we just give them oxygen, but did you give them as well, to prevent damage in their lungs from the pure oxygen? Did you give them vitamin C? Did you give them vitamin D? Did you give them reduced glutathione? Did you give them methylene blue to minimize the damage of the pure oxygen? But just saying that, hey, if you don't go with my way and you don't be intubated, just get the oxygen and that's it. And that's mismanagement of those patients. We need to give them everything that helps to block those spike receptor using ivermectin, methylene blue, and also help to buffer the redox so you can prevent the oxygen damage of the lung. And so banning those patients and telling them that you're going to get the oxygen only and you are not considering buffering the redox, you're causing more damage to the lung. Yes, you have that point of pure oxygen causing damage to the lungs, it's causing generation of free radicals. And so I think there is mismanagement there in the beginning and lack of understanding that we can help to buffer the redox. We can help to minimize the damage of the oxygen, pure oxygen. So this is very important aspect, because most of the patients that myself, when I'm overseas and some here, when we are giving them the whole protocols of buffering the redox, and then they're giving their oxygen supply, which is just oxygen only, up to 80. And I actually see patients to 70 and 50, but if we try to drop it all the way, the parameters to 80, and the oxygen, partial oxygen saturation from 60 to 36, that will be, we can save a lot of people. We don't need the necessary intubation, but still, you still need to give them everything that blocks the spike receptor, that buffer the redox, in order to minimize the damage in the lung. But if you go ahead and you say, no, I just want to go ahead and intubation, well, you have the pressure damage. How are you going to counteract that? I mean, yes, you're getting the oxygen high, but those alveoli are very fragile. They have pneumocytes, they have vasculites, they have thrombosis in their blood vessels. Activation of the angiotensin type 1, type 2, angiotensin 2 type 1 receptor is also stimulating the hyaluronic acid and collagens, and it makes those walls very, very fragile. So your pressure that you're doing, you're blowing up those alveoli. Definitely that patient will not benefit from the intubation. Especially you did not give them any antioxidants in the protocol, no buffering of the redox, nothing of those protocol. We call them integrative doctors that they are giving, and you're doing only the mainstream medicine. You're not protecting those alveoli, and you have no mechanism to counteract the baropressure pressure damage of the lung. So that's my concern about COVID pneumonia versus other forms of pneumonia, which needs to be changed because of different pathophysiology. The protocols needs to be changed and not be treated as acute respiratory distress syndrome, because if you see COVID, it's a mix. It has pulmonary hypertension because you have thrombosis in the capillaries of the blood vessels. It has ASD because, yes, there's alveoli being collapsed due to building up of collagens and hyaluronic acid. Yes. So it's a kind of mixed bag. It also polarized the immune system to Th17, interleukin 6. So it behaved like you have bacterial infections. You have neutrophilia. Neutrophilia is damaging all the wall between the alveoli and the blood vessels of the is damaging it because of the enzymatic reactions and hydrolytic reactions of the neutrophilia. So it's a kind of a mix. COVID has, I think, all the different pathology of all as different pneumonia, along with pulmonary hypertension, along with acute respiratory distress. It's all mixed together, and they have a very fragile wall, which I think I will advise against early intubation. I don't see it. It's right, and I think a lot of people are able to make it without early intubation more than what we have come up with early intubation. What do you think?
So yeah, just to make a comment. So about the reperfusion injury, as you mentioned, is like basically if you have like an ischemia, for example, if somebody has a like a clot in the legs, and and then it's been there for a couple hours, and then now you're taking it out, you have a vasodilation, you have all these metabolite toxins, then you get CO2 production and hypotension and reperfusion injury. Basically, it's inflammation that happens once the perfusion restored. That's not the case here when we do intubation. When we do the intubation, basically you're opening the airway. You're not reperfusing any part of the lungs. You're just opening collapsed lungs. And usually, if that's the problem, if the problem is ventilation or an alveoli, and some of the areas that say they're collapsed, they're not participating, once you open it, you will see dramatic improvements. Before any, like, this is not the same as reperfusion. This is like a collapse, you open it up. If there's a collapsed lung and you open it up, it will have the aeration and will participate. And with the ARDS protocol, we're using low pressure, means like a baro. So we're very aware of the barotrauma. So the pressure has to be kept within lower areas so we don't overextend. The tidal volume is very small. The FiO2 is titrated to effect. So barotrauma doesn't happen immediately. It happens if you accept a very large pressures for a prolonged period of time. But according to the ARDSnet, we use like a 32 for the plateau pressure. A peak airway pressure has to be, below 35 or 36. PEEP has to be around 20. This was not the case here. He wasn't requiring, as I mentioned, with COVID, they're not showing the same mechanics as an ARDS. So we're not struggling with the pressure in their case. We're able to give them, they don't have stiff lung. So you can actually get a good volume, you can have good, but the problem with this patient, all his lungs were damaged. I mean, he was beyond repair. And if you pre-perfusion, you're talking, I mean, I like methylene blue, and I try to introduce it to the pharmacy several times. I send them some articles, we have some discussions, but it's still like, not adapted because the evidence is not there, Dr. Halas. I mean, we have to face it. Mainstream medicine, they are evidence-based. And if you're evidence-based, you have to be consistent. There's no evidence. If anybody present the evidence that is solid from a good source, a lot of people will follow. But the evidence that I've seen so far, nothing really strong that can stand to the medical community. We like to use those alternatives. I'm sure there's a lot of therapies out there that is interesting and intriguing. But without solid evidence and good studies, I mean, just to give you an example, yesterday I was reading an article about using multivitamins for seniors above 65. And this is, they just published that actually taking multivitamins on a daily for seniors above 65, it has evidence that it will reduce aging. And it's a very well-designed study. and it's compelling. So now I was like, you know what, multivitamins is not like, right now when you look at this evidence, like, okay, this is a strong evidence that everybody should have multivitamins when they get to older age because it protects the brain. And that's in the mainstream medicine, that's what really stands. You have to have a solid evidence, a nicely designed study for people to follow. With COVID so far, all what we're doing is based on the best evidence we have, and it's not always there for everything we do, including the intubation. I was telling you, nobody has. I speak like to so many intensivists, and everybody will have different criteria, because even the leaders in whether it's a American Thoracic Society or the Society of Critical Care Medicine, they don't have a very solid opinion about this because the evidence is not there. But I agree with you that, if we have people with silent hypoxemia, and if we accept, a saturation below 90, if the patient is not symptomatic, maybe we can, we can save them the trouble of intubation and the complication and all the risks of stuff that can happen with it. So I'm like, right now, I share the patient with this, and if they're not anxious to get intubated and they're fine, and then I accept saturation below 90. I say, there's no evidence that intubation will improve outcome. Unless I see an end organ damage as a result of low saturation, I'm willing to accept a lower saturation if that means I don't have to intubate somebody. So we try to do the best we can, but this disease is definitely not like anything else we've seen in the past, and it's targeting multiple, as you mentioned, it's targeting the alveoli, targeting the capillaries, targeting receptors in different areas, and it's not an easy to manage, no matter what we do. There's no magic bullet yet here for this.
So do you agree that the COVID does cause clotting all over the body, like because of D-dimers, most of them, they're high. And so we will have some sort of all over the body, sort of ischemia because of those microvascular coagulation from the platelets. So reperfusion injury could be a factor there in COVID, not necessarily in the lung. Well,
I think it's primarily the lung, because we don't see evidence like everything. Like I said, there's no lactic acidosis. End organ damage is possible. I haven't seen it like lately with the Delta variant. That was like early, like previously we had people when they come in and elevated troponin, they have a cardiomyopathy, hypotension we have. But lately I haven't seen it like renal failure or
you don't see D-dimers are high? You don't see D-dimers are high?
Sometimes, yeah. But the D-dimer doesn't mean much by itself. D-dimer could be elevated for any reason, or when they elevated, then we would give them fully anticoagulation. So we're using full anticoagulation if the D-dimer is high, or there's any evidence of clotting, whether it's a DVT or PE or anything like that. So we will feel full anticoagulation. But generally speaking, it's mostly like focus on the lung damage. I see somebody has a raised hand. I don't know if this.
Yeah, hi Bert. This is Dr. Albert Ray. Hi, Dr. Ray. Thanks for coming.
Yeah, I have several questions about one article that I read maybe 10 months ago, where they I think it was written by immunologists, but they talked about the ACE2 receptor. When COVID gets on it, it causes a bradykinin storm, and the bradykinin storm eventually leads to the cytokine storm. But the bradykinin storm not, it lowers your pressure, it lowers your heart rate. But in addition, they said in the lungs specifically, a lot of bradykinin will cause hyaluronic acid to be released. And a lot of the feeling of the hypoxia, when they were debating whether this is really pneumonia or not, a lot of the debate on the hypoxia, that article was saying it's because it's like trying to breathe through jello. If the alveoli are lined with this hyaluronic acid, there can't be any oxygen exchange, and it's very difficult. So I'm wondering a couple things. Also, at the end of the article, they listed 5 medications that have been FDA approved to lower bradykinin. And so what I'm wondering is several things. One, when you see a patient with that lower oxygen level, but the CO2 is okay still, is it possible that the bradykinin is causing that to happen? So the oxygen goes down before you get the change in the CO2. And if so, is anybody using any of those 5 medications? I'm sorry that I'm not familiar with them because I'm a pain specialist, and those medications were new to me. I think they were just new to me, but they were immune reactors. And I don't hear anything in the discussion so far from either you or Dr. Khayata about the use of those medications to try and do something to change the lung situation so you don't wind up having to intubate somebody or ventilate them. And if you can reduce that bradykinin storm early enough and prevent the cytokine storm, you can prevent a lot of the inflammation that you guys have been talking about that causes those further problems. So I'm just wondering, is there any validity to that article, or do either of you remember it? And secondly, how come we're not hearing anybody try it as a treatment? I agree with Dr. H that the vitamins and things and methylene blue and stuff that we use it for a lot of stuff within functional medicine, as well as photodynamic therapy within functional medicine to reduce a lot of these problems. But I'm just impressed that there were 5 FDA approved medications available and nobody has talked about them since.
So I don't know I'd like to look at those medication and see what they are. But like we've used the I don't know if tocilizumab is one of them. Is actually an anti-cytokine medication. We've used that, but then the problem is it can affect the immunity. I mean, basically, when you're giving this, you're attacking the immune response. So again, if I look at these medication and see where they are, the other things like for using to loosen the secretions, there is. It mentioned as one of this is like as a mucolytic medication. He didn't mention any specific names, but I know we use like in the ventilated patients, we go sometimes mucomest or the acetylcysteine. I mean the NAC is same as the Dr. Halas advocate is inhalation. You put it through
Mucomist.
Mucomist, yes, yeah. So mucomist is, if used through the inhalation, it can loosen some of the secretion, and it also has an anti-inflammatory effect as well. So that's a possibility. It's readily available. We use it sometimes. The secretions. I don't know which stage that the secretion happens, because initially it's dry cough. When they're coughing, it's really not producing a lot of secretions, and it's a very thick secretion. They're like thick and white. When the several patients that I intubated with COVID, you go down there. I think I have some pictures, but I don't know if I'm able to upload them. But like they're, let's see if I can share some pictures. But like they're very thick, and the airway is so inflamed. So you can see like inflamed, thick, almost like cheesy secretions that is not easily it can be removed. And you can imagine that what we're seeing, this is like in the trachea where we're putting the tube, we can imagine is the amount of secretions that are actually filling the lungs. So I can see how ventilation can fail even with it, unless we have something that we can like irrigate the lung with to kind of remove these actively. I mean, usually when we intubate a patient, the respiratory therapist, they kind of they kind of irrigate the lungs with saline. They irrigate it, and then they put the suction down, and they are able to secrete some secretions, and that helps in some ventilated patient is to do lavage more like, and then aspirate it. But for these to be very thick, mucomist might work better. Like we sometimes when we have a lung collapse and very thick secretions, mucomist, dilute the mucomist, irrigated with saline, leave it there for a few minutes and then aspirate it.
Yeah.
Now the big question is why this is not being used in COVID. That's a good question, but and again, I think if there's not literature there, people don't have the time to do. I don't know. They're not gonna.
Well, evidence-based medicine in the United States, it's all about big pharma control. They're the ones putting up the money to conduct those big clinical trials. And they will definitely scrutinize any trials that's coming out outside the big pharma. So there's catch and kill. We know that. Talking about evidence-based for methylene blue using for COVID, there's 400 articles, actually 500 articles for methylene blue with COVID. There is 2,000 for ivermectin. Ivermectin, not all of them are in favor, but methylene, all of them are in favor for managing COVID. They will not see it. They will not consider it as evidence-based medicine because the one who decides evidence-based medicine is big pharma and the money that you're going to put to create and conduct those big clinical trials. But if you go through mechanism in pathophysiology, it makes sense. And if we rely on the big pharma, if they're going to make money, that's evidence-based medicine. If it doesn't make money, that's not. Then it's a big problem here because according to the cases that we have, and I think Dr. Mike Beamer has many, many doctors who are prescribing, I think we're talking about 5,000 scripts per month. None of our patients descend into the ICU, have problems just because of the early management.
Yeah.
Now,
Dr. H.
Right.
You also mentioned some things that could be used in the ICU for these patients, but I would like to put in a statement about photodynamic therapy because there is one published study followed up by a larger study that came out with the same results. And unfortunately, politically, it's difficult to get a journal to publish right now. But the study they did, they used riboflavin as a photosensitizer, and then they used the blue wavelength laser and ultraviolet laser wavelengths to charge up the riboflavin, which then kills the viruses. So intravenously, this is something that could be used when somebody is admitted to the hospital or an ICU. If they would do it intravenously, the study that was done did it on people that had stage 3 COVID, but just short of needing hospitalization. But they got people from testing positive to negative in 5 days with one treatment a day. And so that's another area that I think Western medicine has not looked at yet because of politics, not because of medical science. And it's unfortunate because if we strictly look at this whole situation medically, a lot of these things, the methylene blue with wavelength laser, they're all good. The blue wavelength decreases the immune system. It decreases the immune response, which is one of the things we want to do. And it's one of the same things that those 5 medications were trying to do in terms of reducing a bradykinin storm, but using something like mucomist might help with a little bit with the secretions. As you said, they're going to be very thick. Hyaluronic acid is very thick, but that's trying to help a symptom quickly. What the article was referring to with the bradykinin storm and these medications was reducing the immune response in the first place, so that something doesn't keep making more of those secretions and blocking and clogging up the lungs. So I agree with Dr. H that there's a lot of other things that could be added to the current regimes that would enhance their results and get patients better quicker. But I just
Please provide more options, right? You know, or at least more tools in your toolbox.
Yeah, I wish Western medicine were more open to some of these things. And I will tell you, because a lot of what I do is functional medicine, and I will tell you that the studies that the AMA came out with, that vitamin D doesn't do anything and fish oil doesn't do anything, etc. When you look at the studies that were done that they based that conclusion on, the dosages they used were way too low.
Yeah.
And the same thing with the things like methylene blue and the riboflavin. They have to be higher doses to be effective. And unless you do a study with a functional level of those vitamins, you're always going to come out with a result that says people don't need to take vitamins.
Yeah.
Can you still see my screen?
Yeah.
Yes.
Okay, all right. So yeah, here's showing some pictures, like right before intubation.
Oh, Issam, we don't see. Well, we see your presentation still. We don't see a picture.
Okay. Let me see if I can share something different. So share screen. All right. So okay. Can you
there
see
you go. Yeah. Oh my gosh, it looks terrible.
Wow. Yeah.
So this is the video, right? You see the video?
Beautiful.
Yeah. So this is right before the intubation, and you can see the vocal cords right on top here. And this is all these secretion. This is another picture. Let me see if I can. Oh, there's another one. Let me see. But I mean, it tells you the magnitude of when I was a fellow, and I was trying to. I'm sharing this. I was. You can see this picture. Like it's like a flood.
Yeah.
It's like a flood. And I remember when I was a fellow, I was doing a bronchoscopy with one of my attendings. So so I go in there, and I mean, it wasn't COVID. It was like a different type of pneumonia, but this patient has a lung collapse. And then we go inside, and then so basically we were aspirating the secretions, and then we suck it out. We irrigate and we suck it out. The moment we finish, is like a flood with secretion comes out. And being like a fellow, I'm trying to learn. I was like going back and forth. And my attending, he looked at me and he said, "You know what? This is endless. This is endless. You can't clear the lungs like this. I mean, because it's like a spring of secretion.
It'll keep making more. It'll just keep making more.
It's like it's like if you look at it, it's like a flood. I mean, like how much can you take out and how much you can treat, no matter what. I mean, the thing is, everything, if any treatment is given early or anything that can be done early, that's why all this emphasis on treating early, giving viral early, because once that floodgate opens, once that state comes to this point, then the damage is already done. I mean, like when you look at this inflammation, the red and all this congestion, these are all like tissues that are already infected. I mean,
they're already going to die. That you can see that tissue is going to die.
Yeah, you have to generate a new tissues in order to replace that.
Yeah,
and
right.
I think that's the dilemma. Is like, you know, when you get to this point, I see like, you know, vitamin C, vitamin D, methylene blue, all these things are great when the early stage. So like, you know, if you catch somebody the first week of treatment, and then before they get to this, you want to throw everything at them that you know,
Right.
because that's
Dr. Issam, may disagree with you regarding IV methylene blue and the miracle that I saw, and there's many publications that support it. I saw oxygen saturation goes from 60 to 90 just by adding the IV methylene blue. But it's not public. You don't have the mainstream medicine in it because there's no money going there. But I saw it. And I saw patients that my dad, completely dead. I mean, his blood pressure is on, he's surviving through epinephrines, infusion pumps. And we did the methylene blue and we were able to reverse his vasoplegic shock. And he was able back to talk in at least for a week. But no, this is just for
and
prevention.
I have a good story about methylene blue as well.
Right.
I don't know if I told you this, but like my in-laws just got COVID 2 weeks ago in Syria, and then my mother-in-law is not the healthiest. I mean, she's got all kind of medical problems. So when my wife told me, you know, I was like, you know, Syria medical care is not great. They don't have a lot of medication, God knows. So basically, we got on a conference call between me, her son, who's a pharmacist, her father is a pharmacist, and we got all the, you know, try to figure out. And the first thing I asked them in Syria is like, do you have methylene blue in Syria? And then my father-in-law, who's a pharmacist, says, yes, I think I have a jar somewhere in my pharmacy.
I'll find it if I have to.
I said, and he said, it might be an old. I said, you know, it doesn't matter, just go. And so we figured out the dose and how they prepare it. And one of it, he sent his grandson and gave him the instructions of how to, you know, to put it together. So he put it in capsules, and he went back to his mom all blue, all his clothes blue.
Yeah. His kitchen was ruined. His lab,
but he saved his grandma and grandpa. I mean, he gave it to them, and they really felt great. Within a week, they turned around. So I'm a strong believer. I mean, you know.
Let me ask you a question, Dr. Khayata. You know, and congratulations and thank you for your work in critical care. When all of us here are at the end of our lives someday, it will be a person of your training that oversees our fate. And what I would ask you in this situation is, as you know, we've talked a lot about early outpatient treatment. And everybody in the early outpatient treatment with COVID, that whole group of people, they'll know, like you say, to hit it really hard early on. And to, you know, the question though is, what can we do in the early outpatient treatment phase to make your life easier should the patient take a turn for the worse and need to come to see you?
I think they have to, you know, I think that they have to, you know, like follow. I mean, obviously we have to follow the CDC guidelines and do whatever, like whether it's monoclonal antibodies if they were
right,
like, eligible for that. But also, I'm advocate for methylene blue. You know, if somebody comes to me, I'll tell them take a methylene blue. I don't mind prescribing it to them because it's not harmful drug. It's
very safe, and dosages we're using.
Very safe, yeah. So vitamin D, vitamin C, zinc, those things, and nutrition, obviously, rest. And so whatever, I mean, whatever over the counters, I think is something, or like you know, like a functional medicine or supplement is, yeah, if there's no evidence, I think we should advocate for it as an outpatient.
We're doing pretty much what we need to be doing to help them when before hopefully they will never need that additional help. But if they, it sounds to me like if we do those things that we are already talking about, that's all we can do. And then it's just at that point, it's the patient's underlying health that controls the situation.
Well, still, if you got into the ICU and you delay the intubation as much as you can, and the reason why I'm saying that, it's not even by evidence-based medicine. Let's go in Italy. When they start early intubation, they saw a massive amount of death rate. And then they change it. They say, no, we're not going to put any more pressure directly, like those masks, they stick it on the face, very tight, and there's pressure direct into the lung, of course, even with CPAP. They changed the CPAP, and they did the whole body and the helmet CPAP just to minimize the direct pressure on the lung. So even the CPAP they change it in Italy, and they find the outcome is better. So the pressure damage of the lung is way more worse than pure oxygen damage, because we can do something with pure oxygen. We can give glutathione, NAD, methylene blue. We can empower the antioxidants, scavenge the free radicals, but we cannot do anything if we end up with battle pressure injury that is caused by early intubation or early regular CPAP that we are recommending against it. At least if you want to do the CPAP, just start it with the helmet one or the whole body one, and that shows very effective in Italy and reduce the mortality rate. And there's a big company in Texas who is doing those helmet CPAP. It's a big balloon that they put in the head. So the other thing about bradykinins, let's go back to that. Yes, Dr. Albert, right? The ACE2 enzyme is responsible to break down the bradykinins. And so if you block that, then you have too much of bradykinins, and the bradykinins eventually will stimulate the histamine, and you have the histamine syndrome, and the histamine goes all the secretion that you see there. This is histamine. There's too much of histamine. And yes, giving antihistamine is part of it, or giving steroids. We're giving already low dose steroids. And the methylene blue can directly inhibit bradykinins and inhibit histamine. So I think what you are indicating of the bradykinin pathway, it is there. And we are managing by giving this budsinoids, which is cortisones, inhalation,
Dr.
and
H,
methylene blue.
Dr. H,
yes,
steroids don't work on that bradykinin storm. The 5 medications that were listed were not steroids, and they were not antihistamines. They were in that new anti-immune system category of drugs, and I think 2 of them may have been retroviral kind of medications, but they were specifically FDA approved to lower bradykinin, and that's why they were mentioning them in that article. But unfortunately I have to sign off, but before I sign off, I want to thank Dr. Khayata for that presentation. It was very
well. Before you sign up, I need you to introduce the Academy of Oxidative Disorder.
It was not coincidence,
right,
that the movie Avatar had those beings that were bigger, stronger, and healthier than humans blue.
No, it's not. Yeah, that's right. They operate on methylene blue. They have 10% methylene blue.
I like
See you all
that.
later. Thank you so much.
Before you go,
Okay,
please introduce the Academy of Oxidative Disorder. It's led by Dr. Albert Ray. It's that you can get the CME. We're working on this, getting the CME there, and also all the recording videos that we have. It's going to be there in the Academy of Oxidative Disorder, and we need speakers and faculty and submission of abstract, because this is a nonprofit organization entity dealing with all diseases that has to do with oxidative diseases. So are you there still, Dr. Albert?
Yes.
Yeah, if you want to go ahead.
Yeah, very much. We are a new academy, and we are a 501c3 non-for-profit. So we can offer membership to anyone who wants to join. Membership is free, and we are working to develop a CME program that will deal with oxidative reduction problems and diseases that are related to that, which includes most every disease that's being found these days. And that's just one of the things. Our goal is to educate people about the oxidative reduction system and where it all fits together. And Dr. H, your nitromedicine group, I mean, you were the founder of AOSD. And you know that your nitromedicine group is highly related to the oxidative reduction system. So we are very happy to take your programs and incorporate them, and then be able to offer them for CME for physicians or anybody that wants to watch them. But they're going to be, it's going to be arranged so that you have to become a member of AOSD in order to get the CME presentations. But we look forward to that, and we're working on it as fast as we can.
Yeah, that's coming soon.
Yes.
Yeah.
So people who are ready, chronic disease prevention management centers and specialists, they are the most highly qualified to be speaker and faculty. We already developed a summit for that. We're working on it under the Academy of Oxidative Disorders. So we look for Dr. Khayata, Dr. Patel, Dr. Kathleen, all those people are Dr. Joseph, and many more. We have around 10 doctors, Dr. Kevin, Dr. John Ronald.
Dr.
We're
Ortel.
looking for them to join as a speaker and faculty and be highly, and it's completely nonprofit. That's mean there will be no product influence there. It's all science, evidence-based, no influence about the products or companies there. Yes, they will exhibit, but really they have no influence on the way that they're going to speak, or there's no much of direct promotion at all in this organization. We want to keep it completely strictly for research and development, advanced medicine without any bias. And Dr. Albert Ray, he's the president of that organization, and he is the most qualified person that I know who will be able to make it completely zone-free from any commercial influence in that entity, because it's completely nonprofit and it's all about advancing medicine with no influence or any bias or conflict of interest.
Yeah, and any corporate sponsorship to the organization has to be done through an unrestricted grant, so the money can be used for anything that the organization chooses. So you're absolutely correct, Dr. H. There'll be no company buying time with us, is what you're really trying to say. The other thing that I think we should mention, especially to the group that's on tonight, is that part of the way we want to get this organization functioning is to develop a clinical board of advisors, so that we have at least one person from each specialty who wants to become the chair of their group. And someone like Dr. Khayata would be an excellent person to take charge of that respiratory area. And those chairmen are going to be helpfully looking for people that want to make presentations and present CME worthy material, just as we had tonight. If we had already had the approval, this would have been an excellent CME talk.
Right.
So I think if you all have any connections with anyone interested in wanting to take charge of one of those areas, please let us know. We'll be happy to talk with you and get you involved.
Yep. Once we get a critical mass too, we have some bigger people that'll come in and help us. I posted the Academy, a link to the Academy website in the chat. If anybody'd like to click on it, you can join for free. You just click on it and pretty much fill out the simple form, and we will have you in there. We'll see you and begin to communicate. But this is all just kind of getting started. Just oh, there you go. Thank you, Issam.
There you are. Yep.
There you go. Yeah. And so it's essentially trying to inspire interdisciplinary discussion about these kinds of subjects. For instance, between critical care, ICU, and outpatient care, or people who are doing emergency room, or any type of thing, even dermatology, or completely or cardiology. There are oxidative stress disorders related to all of these disciplines, and we're hoping to draw all these people together, knowing that at the end of the day, all these diseases are impacted by oxidative stress and its management, and this management of the dysfunctional signaling and mitochondrial dysfunction. So we're hoping people will want to come and learn more about that, and we're just trying to create a playpen for that to happen in. And the other thing is, it's private, right? It's completely private when we have chats in there and stuff.
Yeah. Also, I think we should mention, I did mention Dr. H was the founding father for the organization, but I should also mention, Mike, that you are our COO. And so we are truly going to be an interdisciplinary organization. Right. And we welcome people from any field of medicine that has an interest in oxidative reduction and the diseases that it causes. So with that, I am a little late, so I have to sign off, unfortunately.
Thank you for coming tonight, bro.
Thank you all for a great meeting tonight. Look forward to seeing you again.
Absolutely. Yeah. Do we have further? Thank you, Bert. We'll see you. I'll see you Wednesday. What about? Do we have further questions for Dr. Khayata on his presentation or anything? Going once, going twice, sold. It's like the car auction, right? You just bought the Corvette for $200,000. But thank you very much, everybody, for attending. Issam, that was awesome. I really appreciate you bringing that in, and it's great to see your point of view on all this stuff and hear your expertise and see behind the curtain of what we don't get to see often, right? Which is what happens in the ICU behind those big glass doors. So we appreciate a glimpse into your world. Thank you.
Yeah. Thank you very much. Have a nice evening.
Yeah. Good night, everybody.
Good night.
Good night.
Yeah.